Now, this topic or this area in interventional cardiology has been an area of controversy since long. We know that approximately 50% of the patients who are presenting with STEMI, they have at least one other vessel having a significant, at least more than 50% stenosis in a non-culprit artery. And presence of obstructive lesions in a non-culprit artery has been historically shown in the scientific literature to be associated with a worse short and long-term outcomes. Now, whether these non-culprit lesions along with the infarct-related artery needs revascularization has been controversial. Old guideline recommendations, they advise against non-culprit vessel PCI in the absence of any spontaneous myocardial ischemia or intermediate or high-risk features and invasive assessment. Now, the question is that compared with the culprit-only percutaneous PCI, is a strategy of complete revascularization with multivessel PCI can be associated with a decreased cardiovascular mortality in STEMI, and whether the association of fractional flow reserve or angiography-guided complete revascularization approaches are used. Now, as you know, the present guideline recommendations, the ESC 2017 guideline, after a series of studies, namely the starting from the premise study, the Dynamic 3 primality, and the culprit trial, they have upgraded the recommendation of complete revascularization in primary patient from class 2B to class 2A recommendations, and they are based on mainly on these 4 trials. We'll briefly go on these 4 clinical trials. Now, which has shaped this guideline recommendation, it mainly is driven by these 4 trials: the primary trial, the complete versus the lesion-only primary PCI, or the culprit trial, the Dynamic 3 primality, which is an FFR guided trial, and the compare acute trial. All these studies has been published in and around between 2013 to 2017. Now, in these studies, if we dissect the studies closely, we'll see that the PCI of the non-infarct artery was done either during the index procedure itself while opening the IRA in PRAMI and in compare acute study. It was staged during the same hospital admission in Dynamic 3 primality, and anytime before discharge, which can be on the day of index procedure or before discharge anytime in culprit trial. Now, indications for PCI non-IRA was angiography-guided lesions with more than 50% stenosis in PRAMI, more than 70% stenosis in culprit. So in these 2 trials, it was primarily angiography directed and FFR-directed revascularization in Dynamic 3 primality and compare acute. It was seen that these 4 randomized clinical trials, first is a primary trial, which was done between 2008 and 2013 in 5 centers in the UK. Infarct-related PCI versus the other group was randomly assigned either conservative management or the non-infarct-related PCI. It was seen that the patients with STEMI and multivessel CAD undergoing infarct artery PCI, preventive PCI in the non-infarct artery was with a major stenosis, it significantly reduced the risk of adverse cardiovascular events as compared to PCI, which was only limited to the infarct-related artery. The culprit trial was a trial with similar design, where in one arm, the patients were stratified based on infarct location and symptom onset, and the primary composite was all-cause death, recurrent myocardial ischemia, or repeat MI, non-fatal MI, heart failure, ischemia-driven revascularization within the next 1 year. And it was seen that in the primary composite endpoint, it occurred in 10% in the complete revascularization group versus 21% in the infarct-related artery only revascularization group. So the complete revascularization group fared significantly well, and it was statistically superior seen in the complete revascularization, and the trend towards benefit was seen very early even after the complete revascularization. The curve diverged and achieved a point of statistical significance even only within 30 days after the procedure. So it was quite a superior trial, though neither of the primary endpoints was statistically superior, but all showed a trend towards superiority, which culminated totally into a statistical superiority. So the conclusion was that in culprit trial with a multivessel disease, complete revascularization possibly lowered the rate of composite primary endpoint at 12 months compared with treating only the IRA. Another similarly designed trial was a Dynamic 3 primality, but the differentiating factor in Dynamic 3 was that these revascularization in the non-infarct artery was guided by the FFR values, and the follow-up was longer for up to almost 2.5 years. Events comprising of the primary endpoint was recorded in 22% of the patient who has PCI of only the infarct-related artery versus only 13% who had complete revascularization. So this study also established the superiority of total revascularization or complete revascularization post-MI.